Welcome, my name is Gabriela Quintana, and this presentation will address fruit and vegetable consumption among those experiencing homelessness in the prevention of diabetes. Diabetes is a chronic condition affecting 8.2% of adults in the US. The estimated homeless population in the US was around 630,000 at any point during 2012. Up to 1.2% of the US population experiences homelessness over the course of the year. The rates of diabetes in the nation's homeless population are up to 18%. Those experiencing homelessness often have limited budgets, contributing to food insecurity. This leads to a lower consumption of those more expensive, fresh produce such as fruits and vegetables, which in turn increases the risk for several chronic conditions such as diabetes. While the rates of diabetes among the general population are notable, it's astonishing to see the prevalence of diabetes in this target group is more than double when compared to the nation. The Center for Disease Control and Prevention states diabetes protective factors to be regular physical activity, losing weight, and eating healthier, like including more non-starchy vegetables such as broccoli, spinach, and green beans. The risk factors called out by the CDC are being overweight, physically active less than 3 times a week, being 45 years or older, and being African American, Hispanic or Latino, American Indian, or Alaskan Native. Though not identified by the CDC, income and housing status severely impact access to protective factors, such as those non starchy vegetables, and therefore experiencing homelessness can be considered a risk factor. The socio-ecological model can help us understand how different components of an individual's life affect their health behaviors. In this case, there are many factors that influence the consumption of fruits and vegetables among those experiencing homelessness. At the individual level, low self-esteem, knowledge, and living situation can contribute to behavior decisions. Families and social networks may have certain beliefs or values which can influence the foods eaten. Community programs, such as shelters, health programs, and food pantries, can affect an individual's nutrition. At the policy level, programs like WIC or food stamps can dictate which foods will be accessed by individuals. The modifiable behavior addressed here is fruit and vegetable consumption among those experiencing homelessness. Housing and income status are a pillar of well-being that often determine the status of other determinants of health. Those experiencing homelessness or unstable housing often have limited resources, resulting in inadequate nutrition. These eating behaviors are often the result of not just access issues, but limited knowledge pertaining to both the benefits of eating fruits and vegetables and how to change the behavior. We will now look at how etiology studies have been used to understand the fruit and vegetable consumption behaviors among those experiencing homelessness, as well as interventions developed through theory to increase individuals' intake. The Health Belief Model, or HBM, contributed to the development of a questionnaire used in a barrier analysis to identify environmental factors that determine fruit and vegetable consumption behaviors in low-income adults. The analysis was carried out in communities in both Vietnam and Nigeria to compare the responses of low-income individuals who both practiced the behavior of daily fruit and vegetable consumption as well as those who did not. In Vietnam, habits and perceptions were main contributing factors in food choice behaviors. The doers had family preferences and habits, which made daily consumption easier and also identified the benefits of the nutrients gained from healthy eating. The non doers experienced limited access to fruits and vegetables and had low perceptions of action efficacy in consumption, protecting against chronic health conditions. In Nigeria, affordability was the only main difference between the two groups, as doers identified affordable fruits and vegetables as an enabler to regular consumption. The barrier analysis also identified perceived benefits such as those to beauty, skin, and weight management, as well as social norms such as religious beliefs. The Health Belief Model guided Farm to Fork, a program to increase fruit and vegetable consumption among those utilizing a food pantry. Participants' initial barriers to this behavior were access to produce, perceived value of produce for health, and lack of confidence on how to use fresh produce. By distributing produce to food pantries regularly, providing education on fruit and vegetable consumption health benefits, and produce use and recipe education, these barriers were addressed. Not only did consumption increase, but there was also an increase in the health value of consuming fresh produce. By combining education, which improved attitudes surrounding healthy eating, with access to produce barriers to fruit and vegetable consumption are eliminated in low-income communities. In order to understand the behaviors behind the food choices made by those experiencing homelessness, their motivators must first be analyzed. While food cost may be the obvious factor in decision making, interventions can be developed to address barriers such as perceptions and beliefs surrounding the accessibility of fresh fruits and vegetables. The health belief model is an effective tool in examining these barriers and implementing appropriate interventions to increase fruit and vegetable consumption in individuals experiencing homelessness as a preventative measure for chronic diseases such as diabetes. The trans-theoretical model of change has been used to examine the correlation between an individual's fruit and vegetable consumption and where they stand in their behavior change process. Focus groups carried out with disadvantaged African American adolescents in New York City used the TMC to investigate the process of this health behavior change. The individuals in the action to maintenance stages had higher fruit and vegetable consumption than those in contemplation and pre-contemplation stages. They also perceived much fewer cons, such as fruit and vegetables are too expensive to buy, and more pros, like fruits and vegetables are good for my body, to increasing their consumption than those in the earlier stages. The TMC has also been used in focus groups to understand how individuals experiencing homelessness at a shelter perceive the concept of healthier eating. In this case, more than half of the participants thought about improving their diets often, but felt a lack of control in their environment was preventing them from doing so. A campaign based on the trans-theoretical model of change targeted at SNAP-eligible adults in Ohio, Celebrate Your Plate, rolled out a variety of low-cost tasty meals social marketing messages. A survey was then administered to identify respondents' exposure to health campaigns and health behaviors, including fruit and vegetable consumption, and perceived barriers to eating fruits and vegetables. The study found that those exposed to the campaign were further along the stages of change, somewhere between preparation and action, for both fruit and vegetable consumption, than those unexposed, who were on average in the preparation stage. The TMC also guided a multimodal intervention to improve fruit and vegetable consumption in economically disadvantaged young adults throughout 10 states. This program identified participants' initial perceived daily fruit and vegetable intake, stage of change, decisional balance, processes of change, and self-efficacy. The intervention consisted of colorful mail materials and educational phone calls, which resulted in an increase of fruit and vegetable intake within the experimental group and no change in the control group. The study also identified that self-efficacy was higher in those who either entered at or progressed to the action maintenance stages than those who relapsed or failed to progress past the preparation stage. Health promotions such as these can act as consciousness-raising and stimulus control processes to influence and support stage transitions. Understanding the trajectory of individual health behavior changes are vital in the development of interventions to improve food choices made by those experiencing homelessness. The trans-theoretical model of change is a valuable theory to identify how ready individuals are to increasing their fruit and vegetable consumption. In one study based on the social cognitive theory, focused on children in homeless shelters and their food-related behaviors, found that often children and their families experiencing homelessness are lacking stability in several aspects of their lives, including nutrition. Families emphasize the unreliability of the next meal, so overeating is often encouraged, even when the food selection is poor and lacking in nutrients. Overeating is the outcome of a behavior carried out to maintain satiety and decreases an individual's perceived self-efficacy to consume more nutritious foods, such as fruits and vegetables. Another study investigated the relationships between housing instability/food insecurity and diabetes efficacy in low-income groups, and how this varied based on living situations. The study found that both housing instability and food insecurity result in lower diabetes self-efficacy, with the most significant correlation seen among those lacking a usual place to live. Inadequate housing and lack of access to fruits and vegetables can affect the behavioral capacity to consume nutritious foods among those experiencing homelessness. A multi-level intervention to increase fruit and vegetable access and intake first investigated factors affecting fruit and vegetable consuming behaviors among residents in a low-income neighborhood. In addition to identifying limited access as a barrier, participants also wanted to better understand the preparation of these foods. This intervention combined a variety of methods, including accessible fresh fruit and vegetable markets, motivational and educational materials, campaigns, recipe cards and videos, newsletters, and cooking demonstrations to increase self-efficacy for fruit and vegetable intake and address outcome expectations. Along with increasing availability and education, this intervention also targeted outcome expectancies by implementing recipes to change taste perceptions. A community-based nutrition education intervention combined with food baskets targeted at low-income Latinos in the Seattle metropolitan area found that designing a program with cultural considerations increased vegetable consumption. The components of the intervention included group discussions, cooking demonstrations, take-home food baskets, and targeted newsletters, which all corresponded to various constructs of the social cognitive theory. After the 8-week intervention, it was noted that participants had an increase in vegetable intake, as well as knowledge, perceived barriers, food efficacy, and food outcomes compared to before the intervention. The social cognitive theory has been proven to be a reliable framework in understanding fruit and vegetable consumption among those experiencing homelessness, as well as in the development of interventions to increase the intake of these foods in this population. The proposed intervention, after analyzing successful studies and programs as well as considering the needs of the population, is peer-led nutrition groups at community homeless shelters. This intervention, guided by the health belief model and social cognitive theory, would consist of engaging groups led by peers currently experiencing homelessness or those with prior lived experience. This program would be for individuals experiencing homelessness, including those temporarily residing in a shelter, unhoused, or recently housed. Each session would have an educational component as well as provide food. Theory construct used in the design of this intervention include perceived barriers, perceived self-efficacy, perceived benefit, knowledge, outcome expectations, behavioral capability, and observational learning. The program is formatted to fit the needs of individuals experiencing homelessness. Often transient individuals, a long-term program structured by modules or cohorts would be less than desirable. Instead, we need to meet our population where they are. Geographically accessible community shelters are the ideal setting for this program. Here, individuals that are unsheltered, recently housed, or have temporary accommodations can meet for one or both of the 2 meeting times identified through a needs assessment survey. The sessions will be formatted the same week to week and be an hour and 15 minutes long, following the same structure but with new topics and recipes each week. Participants can come to the group and share any insights they've gathered from the previous session and then sit for the first learning component. This will cover topics such as how to access fruits and vegetables in the community and leave room for questions about social services and programs. Other topics will include the health benefits of fruits and vegetables and the risks associated with inadequate consumption. The next component would be observational learning, no longer than 15 minutes. A peer leader will demonstrate how to prepare the food in a different way each week with special considerations for the target group, which don't usually have access to self-use kitchens or refrigeration storage. The goal here is to address behavioral capability by having a peer demonstrate the process. As the demonstration concludes, participants will come together to eat or taste test the product, which will address outcome expectations related to making fruits and vegetables taste good. Finally, peers will hand out boxes to participants, which include food as well as instructional cards to prepare the food the same way they saw it done in the session. The box will also include the topic for the next week so individuals can look forward and prepare to returning. Possible ethical concerns with this program would include the location. Some individuals may have reasons to avoid the shelter. In terms of personal preferences, certain sessions may not be accommodating to all allergies, religious customs, or other personal needs. When thinking about storage, the food boxes should be appropriate for individuals that are unstably housed without usual commodities such as refrigeration, transportation, and kitchens. The educational component could also be too long for some individuals who may just have the time to stop by and pick up a box. That concludes this presentation. Please feel free to reach out with any questions, comments, or concerns. Thank you.